The next session is dedicated to dialysis access, and we're really excited to have a number of wonderful papers that deal with this very important topic, bread and butter topic for vascular surgeons. So without further ado, why don't we start with the first paper entitled Functional Impairment is Associated with Poor Outcomes After AV Access Creation, to be presented by Scott Levin from Boston Medical Center.
Good morning, everyone. I'm Scott. I'm a surgery resident at Boston University. Thank you so much for having us do this talk. And here are our disclosures. So functional impairment affects outcomes after a variety of vascular operations. The degree of physical activity dependence and degree of self-care has generally been associated with perioperative complications, readmission, mortality. And functional impairment portends complications in the general hemodialysis population. For instance, impaired ambulation in dialysis patients has been associated with increased mortality. However, the impact on outcomes after arteriovenous access creation in particular is unclear. So we sought to evaluate the relationship of patient ambulatory status and ability to independently perform activities of daily living with arteriovenous access outcomes. We conducted a retrospective cohort study using single-center data from 2014 to 2020. Patients included those undergoing AV access creation. The exposures in the study were assisted activities of daily living, or ADLs, and assisted ADLs were considered dependents in one or more of the domains of ADLs, including eating, bathing, dressing, transferring, toileting, walking, or moving around. And we also evaluated impaired ambulation. Outcomes included 90-day readmission, 1-year primary patency, and 5-year survival. So the patients, there were about 689 receiving AV access creation. Mean age was about 60 years. The majority were male and Black. Access type included brachiocephalic and 41%, followed by brachiocephalic, and a quarter patients radiocephalic and 13%. Prosthetic grafts were used on minority of patients, 13%. Looking at patients with information regarding ADL, there are about 577 patients with this information, and about a quarter of those patients required assistance with ADLs. Looking at ambulation, about 35% of patients had impaired ambulation. And then looking at the outcome of 90-day readmission on univariable analysis, just looking at ADL assistance, there was ADL assistance was associated with higher 90-day readmission, 55% versus 41% without ADL assistance. And then looking at 90-day readmission using ambulatory status, we found that impaired ambulatory status was associated with higher 90-day readmission, and 58% compared with 39% of those without impairment. And on multivariable analysis, we found that ADL assistance and impaired ambulation were each independently associated with a higher odds of 90-day readmission. Then on our Kaplan-Meier analysis evaluating 1-year primary patency, we found that ADL assistance compared with no ADL assistance, there was no difference in terms of primary patency. And then for impaired ambulation, there was a difference for primary patency with 44% of those without impaired ambulation having primary patency at 1 year, and 30% of patients with impaired ambulation having 1-year primary patency. And then on multivariable analysis, we found that ADL assistance was not associated with 1-year primary patency, and nor was impaired ambulation. On Kaplan-Meier analysis for 5-year survival, we found that ADL assistance was not associated with a difference in 5-year survival, but impaired ambulation was associated with worse survival. 53% alive at 5 years among the impaired ambulatory group, compared with 74% alive at 5 years in the no impaired ambulatory group. In a multivariable analysis, we found that ADL assistance and impaired ambulation were each associated with increased 5-year mortality. In conclusion, impaired ADL and ambulation are associated with increased perioperative readmissions and long-term mortality. There was no association of functional impairment with access-specific outcomes, and half of patients with impaired ADLs and impaired ambulation were not alive at 5 years. So it's important to set outcome expectations with patients who have impaired ambulation, as well as prospectively examine the impact of pre- or postoperative physical therapy and visiting nurse services for patients with functional impairment. Thank you. I'll take any questions.
Thank you, Dr. Levin. This paper is now open for questions and discussion.
Sure, very nicely given talk. Maybe just to start, as people are coming up to the mic, you went through it, I think, very quickly on one of your slides, but 2 questions. Was the TDC rate increased in patients with impaired ambulation? And does the study possibly argue for a category of patients that may benefit from primary TDC use?
Those are great questions. In response to the first question regarding TDC rates based on functional status, overall a TDC rate was about 60% in the study, and there was no difference in TDC rates based on ADL assistance or ambulatory status. And then in regards to the second question regarding should we be considering TDC placement as the primary modality for hemodialysis in patients with functional impairment, possibly to temporize them to until they're fit enough for AV access creation surgery. I think our study showed that TDC was associated with increased readmission, independently associated with increased readmission. It was also associated with increased access occlusion at 1 year, but it didn't appear to have a difference in terms of 5-year survival. So it appears the benefit of TDC, it's mixed. It may be associated with decreased readmission if it's placed prior to access creation. That may be related to getting patients on dialysis sooner and decreasing their readmissions for kidney disease progression complications, but it is associated with increased access occlusion, and it had no bearing on long-term mortality. So I think the benefits of it are mixed.
Thank you.
So are you arguing more for prehabilitation of these patients, and specifically what type of prehabilitation are you arguing for that may be able to change these results?
Yeah, that's a great question. Are we arguing for prehabilitation? We didn't directly study the effects of prehabilitation on patients with functional impairment, but we are postulating that that given that patients with ambulatory impairment and ADL assistance had appeared to have poor outcomes, that perhaps physical therapy intervention prior to surgery, referring them to PT, might be associated with improved outcomes in the long run. But that would be a great study for future prospective study.
Yeah, very good study. Congratulations. Considering that 50%, 40 to 50% of the AV fistulas do not mature, and looking at these patients, I would wonder whether we should not be so paranoid about creating an AV fistula in this subgroup, maybe more generous in doing the AV grafts so that we don't get them readmission, reintervention, etc.
That's a great question. Should we be as aggressive with autologous access, or should we be considering grafts, or even or as we discussed earlier, primary TDCs? I think we don't have enough data based on this study to suggest one over the other. We are seeing though that patients with TDC access at least have poor occlusion at 1 year, and so we can't necessarily argue for TDC placement in these in functionally impaired patients as the first line.
All right, excellent. Thank you very much.
Thank you.
Our next talk is Obesity Does Not Impact Early Outcomes of Endoscopic Assisted Arteriovenous Fistula Creation, and will be presented by Dr. Almhani.
Good afternoon. We have no disclosures. It's not moving forward. Brachiobacillic fistula curation is the preferred access option in patients without adequate cephalic vein or radial artery. Endoscopic approach has been described with the advantage of avoiding long arm incision. However, outcomes in obese patients are not described and was the aim of our study, as well as the step-by-step surgical approach. Endoscopic vein harvest is performed using Mackay Hemobro 2. It's the same equipment used for lower extremity vein harvest. It has, as shown in the pictures, a dissecting cone, vein hook, and cautery, and its use will be demonstrated in the next few slides. The bacillic vein and its tributaries are marked with the ultrasound, and the procedure starts with the trocar insertion through a 2 centimeter transverse incision just above the elbow crease. Carbon dioxide is insufflated to create the working tunnel. Here is the working tunnel created by the dissecting cone, and the bacillic vein is dissected up all the way to the axilla without creating multiple competing tunnels. Crossing nerves over the bacillic vein are identified and preserved. The vein hook and cautery are used to divide the tributaries. However, tributaries larger than 3 millimeters are tied with a 3/0 silk tie through a separate stab incision, as the right picture shows. After that, the bacillic vein is exteriorized through a counter incision in the axilla after harvesting additional vein in the upper forearm to allow length for tunneling. Once exteriorized, tributaries are tied or oversewn with 7/0 Brolin, and the superior aspect of the vein is marked to avoid twisting. The bacillic vein is passed through the tunnel using a tunneler, and abscess of torsion is confirmed. After that, an anastomosis end to side with the brachial artery is performed using 7/0 Brolin suture. We had 13 patients, majority were male, with a mean age of 64 years. The commonest comorbidity was hypertension. 70% of the patients were obese. However, the technical success and the maturation rate was 100%, and overall primary patency and secondary patency were 80% and 100%. Our limitations were small sample size and the retrospective nature of the study. In conclusion, obesity did not affect the technical success, intraoperative complications, maturation rate, or patency. We would like to thank SCVS for the opportunity to present. Thank you.
So I have a question while people are coming up. So this is really exciting. It's a really nice procedure. How do you, as you go forward, are you going to be doing all of your procedures using this technique? Because I noticed your procedural time is 300 minutes, so that's 5 hours. which is way longer than most basilic vein transpositions. So how do you take that into account as you move forward in adopting or partially adopting this technique?
Thank you for your notice of the procedural time. This procedural time concluded all the setup time from the patients entering to the operating room with the preparation of the anesthesia and until post-surgical recovery. We couldn't identify the exact procedural time, but as from the surgeon's experience, I can tell you it would be around 3 hours, not 5 hours, only the surgical time.
I think
Guillermo
time for one
Emery.
question.
I think that all of us in this room are a little bit behind that we haven't embraced endoscopic vein harvesting in general, at least for saphenous. I think we underuse it. We do the big incision. I actually use this technique for some of my saphenous exposures. I will say it's kind of bulky to do in the arm. The actual insufflator thing would probably take up a third of the arm. I like the idea of what you're selling. I'm just not sure. Sometimes the elevation in a fat arm is going to move your incision more medially. I'm just wondering, do you have any limitations of what patients you wouldn't do this on? And is there a move in your group to always do this for basilic transpositions?
Well, in our patients, we didn't face any problem with that matter you are explaining to us, so I don't think we have that issue. If Dr. Talarita wants to explain more about it and answer your question.
That's a very good point. So we make about 2 centimeter incision right where is between the basilic vein and the brachial artery as we are doing, we are ready for the anastomosis. I didn't experience any of those problems you encountered. Actually, it's pretty fast, the dissection. It's a very short distance compared to, the entire saphenous vein. So one thing we notice in obese patient is that you can have what is called a pulsatile tunnel, which means that the CO2 doesn't stay in the tunnel, but dissipates in the subcutaneous tissue. So how we do, we overcome that, we increase the target pressure and the flow volume of the CO2 to keep the tunnel open. It's longer than a normal, open surgical brachial basilic fistula creation. I think over time, as any new technique, will get shorter and shorter. Thanks.
Thanks. I think, sorry to stay on time. We should continue with the next talk. Thank you.
Thank you.
Thank you. All right, the next talk is entitled High Prevalence of Social Determinants of Health Insecurities in Hemodialysis Access Patients in a Safety Net Setting. The author will be Max Zhu.
Hi, everyone. My name is Max. I'm a third-year medical student at the BU Chobanian and Avedisian School of Medicine. Thank you all for the opportunity to present our research. And these are our disclosures. So end-stage renal disease is a disease that affects around 786,000 people in the United States. And unfortunately, the social determinants of health, such as socioeconomic status and race, have been shown to affect and create disparities within access to hemodialysis treatment, such as increased rates of tunnel dialysis catheter usage over arteriovenous fistulas. At our institution, we have a social determinants of health screening tool titled Thrive that's been implemented within our EHR system. It assesses for living situation, food insecurity, difficulty paying for medication, transportation, and utilities, caring for family and friends, and seeking a job or more education. So this is a single-center study that looked at all patients from 2017 to 2021 with social determinants of health survey completed within 1 year of their access creation surgery. And we also looked at referrals to our preventative food pantry. Key outcomes of interest included rate of non-autogenous access formation, rates of preoperative hemodialysis through catheter prior to access formation, 30-day ED visits, 30-day readmissions, and 90-day mortality. The mean age for our study population was 59 years old, 38% were female, 64% were of Black race, 20% Hispanic ethnicity, and 57% had tunnel dialysis catheters preoperatively. Of the access types created, a majority were brachiocephalic, followed by brachiobacillic, radiocephalic, and around 14% were prosthetic grafts. So within our study population, we found that the main disparities included difficulty with transportation to medical appointments at 18%, food insecurity at 16%, and difficulty paying for utilities at 13% and medications at 12%, as well as 37% of our patients required referrals to our food pantry. On univariable analysis, neither having at least one of these social disparities identified on our social determinants of health survey nor food pantry referral led to significant changes in rates of non-autogenous access formation, patients presenting to care already receiving hemodialysis via catheter, or rates of 30-day ED visits, readmissions, or 90-day mortality. And these results continue to remain insignificant on multivariable analysis when adjusting for age, race, gender, insurance status, and medical comorbidities. So in conclusion, social disparities are highly prevalent within our hemodialysis access patients, most notably for transportation, food insecurity, and paying for utilities and medications. At our safety net hospital, which has a mature social support system and teams, as well as in a state that has more access to welfare services, we fortunately did not find any differences in health outcomes between patients with social disparities versus those without, but further studies are necessary to extrapolate these findings to more diverse health settings. Thank you all for your time, and I'm happy to answer any questions.
Could I ask you to elaborate a little more on what the social services are that are available? Because I think these are actually really remarkable results, and you found no significant difference.
Yeah, so I think one of the really big ones is that we have the food pantry referral. So any provider, including a vascular surgeon or primary care, is able to refer a patient to that, as well as just in general in Massachusetts, there's a lot of access to local food pantries that we're able to also provide referrals to, as well as SNAP benefits. And if patients do not already have or have limited Medicaid, we have a great social work team that's able to kind of help them in terms of medications.
Congratulations on this paper. It's an outstanding presentation, and you highlight some very important issues. In our practice, we've discovered that transportation really is a huge issue for our patients. Just getting them to the hospital, for a fistula can be actually overly, very challenging, and afterwards they need somebody to take them home with them. You mentioned a little bit about some of the resources that you have at your hospital, but do you think there's a role maybe for some kind of perhaps reimbursement at a policy level to help with some of these issues, like specifically transportation?
Yeah, I think one of the reasons why we wanted to conduct studies like this is that we hope that kind of having this proof in the research is able to then translate to a more policy level. So I'm not as familiar with Massachusetts, but I know that when I lived in California, one of the resources that some of the social work at our hospital was able to offer was bus tokens to patients. And I think that was one intervention that helped increase presentation to care. And we're hoping that by having kind of this data to support that this is a barrier that patients actually face in their care, that this can help push policy towards this direction of making transportation more accessible and equitable.
Right. Thank you very much.
Thank you.
So next, I'd like to move to invite Rana Afifi for our invited presentation entitled Strategies to Overcome Health Insecurities.
Good afternoon, everyone, and I would like to thank the committee for the invitation to speak today. This is following, of course, the talk that we've just had. I would try to talk today and kind of explain that there are some strategies that maybe we can take to try and overcome some of the health insecurities that we've just heard about over the day. Those are my disclosures. So what is the definition of health insecurity? It is the feeling of uncertain, anxious, and vulnerable about the ability to obtain or sustain adequate healthcare services today or in the future. So when patients, for any reason, that can be multiple reasons for that, just like we've heard before when we talk about social determinants of health, all of those factors can actually cause that insecurity and can be a barrier to getting healthcare. Whether we're talking about economic stability, that includes income, employment, food security, housing, Education is an important aspect of it as well, neighborhood and built environment, social community and context, as well as healthcare access, such we just heard, transportation as part of that. We're talking sometimes as well as health literacy, explaining to the patients in their own language and understanding what they're having to go through. So any one of those factors is a factor that can influence a health security for those patients. So there's plenty of literature in the data. Plenty of data in the literature. If you go and look at it, you're going to see, and we've seen in previous talks today, that there's a significant increase in number of publications that actually show correlation between social determinants of health and outcomes. However, what's lacking is the data regarding how do we do any strategies to improve that, implement that, or actually have any intervention in that. So if you look at the strategies to improve healthcare security, we heard the word policy. So that's something that we think about. It's something that right now is at the top of the agenda among health policymakers globally. So if you go to, for example, the World Bank describes social protection in health as a mechanism for assisting households and communities to better manage financial risk and caused by health expenditure, to try and provide support to the critically poor patients. Many of those are aimed at trying to remove some of the financial barriers that we know. Some of those policy reforms do exist, not as much as we would want them, but some of them happen in certain different parts of the world, some in the US, globally, and in other countries. Sometimes it's even more emphasized. Such as the accountable care organizations, where health systems are paid a contractually agreed amount per patient for all health needs, and incentivizing them for efficient and effective care. So those things do exist. Centers of Medicare and Medicaid have also invested in identifying and evaluating innovative strategies for screening and addressing social determinants of health. However, even though there are some of those reforms that are existing, we're still talking about it. We're still not being able to change it or influence it. So obviously that alone is not enough. We do need to have our own advocacy groups. We should support that. Policy change is something that we want to strive to. However, while we're waiting for it to happen, what can we do in our own level of institutions, systems, offices, and our own patients? So there are multiple levels that we maybe can also intervene. So when we look at we've heard today social determinants of health screening. We've heard the word, we've seen one of the screening tools that was presented in the previous talk. Despite us all talking about it and wanting to do it, studies have shown that less than 20, maybe 20% of clinicians do use screening for social determinants of health in their clinical practice. In vascular surgery, that's probably even less than that. Some of the barriers that have been mentioned about it is lack of comfort of physicians to ask patients about some social needs, lack of confidence in our own ability to help patients address those social needs, of course, lack of time and resources, and availability of standardized screening tools. Some of them have not been validated as well, and challenges with integrating that screening tool into existing workflows. So most systems do not have those screening tools incorporated into their electronic system. So it's not as easy to find ways to actually include it in your workflow. Of course, at the patient level, there are the barriers by themselves of language, like we've said, health literacy, and other aspects of even patient having access to such surveys. So those are just examples of some of the screening tools that do exist out there that are used. Some of them would have between 10 to 15 core questions. Some of the studies can be as simple as 3 questionnaires, even at the entrance or admission to the hospital, and then based on that go for a more detailed surveys. So it's not necessarily something that's very complicated. Those are things that can be administered and used. So this is an example of a healthcare system. Prime Healthcare System had published their experience. So it's a system that's across the U.S. with multiple hospitals that work within it. They decided that they were going to do a quality improvement project, and part of that project was to try and see if they do have more social kind of support and help for their patients, how would that influence and how can they implement that. So what they needed to do is identify and initiate the phase. So they started with identifying that as a priority. They got the buy-in from the leadership in that hospital. Eventually, they went to how do they plan it and how do they implement it by identifying the tools and what they need to do. So they ended up incorporating some of those surveys into their electronic system, healthcare system by having a questionnaire of 3 questions at the entrance to the hospital and admission, followed by a more extensive questionnaire at the discharge level. They've built a multidisciplinary team that includes physicians, social workers, administrative, people that are going to help the patient in all aspects of care and addressing their issues after discharge. They've designed and to implement care interventions per patient. So here is something that we've discussed, and we had discussion earlier in the morning. Is it per demographics, zip code, race group, or is it per patients? And I think some of the approaches about per patients are more accurate because each patient has their own independent needs. And in this system, they can give you examples of patients that they took and addressed their own issues. And then they had a large network of resource for partners who are going to help you once the patient's out of the hospital. Because the cause is not just deal with it when they're in the hospital. What do you do when they're out? What do you do when they're outpatient? How do you prevent them from coming back? How do you build something that can have a bidirectional flow so you can actually have that continuous care? And so they were able to go through all these systems by addressing some of those issues. So this is an example of how their system looks like once you take a patient and you go into their EHR, and then basically what you can see is some of their questionnaires. So this is a patient that the income, financial resource is not an issue, is not a risk. However, this is a patient that needs transportation. This is a patient that also had described as that there is food insecurity that is present. So there's different, and you can open the patient's chart and basically identify what are the specific insecurities for those patients. Based on that, you can basically direct them and see that this patient is probably going to be needing assistance in transportation in order to get to the hospital, outpatient clinic, or are they going to need help with food? They were able to show actually decrease in readmission, 30-day readmission dates from before implementation of this system to after implementation of this system. So it's pretty impressive that they were able to do that. They did it for almost 50,000 patients in their system. So I'd focus on certain things that they did, but I think also expanded a little bit on it, and I think anyone in the system, in the room here can do that. It doesn't have to be at a hospital level system. It can also be at your clinic level. It can be at your department level, and it's not necessarily just at a big system. This is something that I think we can implement at different levels. So education is part of it. So giving and creating educational service groups for patients with specific illnesses. So if you're treating and you're focusing on peripheral arterial disease, you might want to think about creating a support group for some of those patients, their families, and basically have more involvement with them. If you're focusing on dialysis and end-stage renal disease, then that's going to be your focus group. If you're doing aortic dissection and patients with aortic disease. So basically you can do very focused support group for patients that are going to give them education, ability to speak, and feel actually that they're not alone. Community engagement in general, talking about prohibitive here, you can also address the risk factors, talk in general about things that you need, even things that are simpler than that, just doing CPR certification courses so you can have more people who are qualified in the community who are able to give CPR assistance in case of emergencies in those communities. We can talk about financial assistance. Some of those systems, for example, this hospital had they had a financial assistant policy to help the uninsured and underinsured patients. They basically used federal poverty level guidelines to decide which groups they can actually help and give them that kind of financial support and relief of their care, and that ensured that patients who financially are unable are actually getting the care they need. They can collaborate with shelters, low-cost housing communities. There are a lot of nonprofit organizations that can help with that. If your patients, and they gave an example of a patient that did not have any housing, partnering with one of those communities is going to be something that you can actually take that patient with the social worker and administrative that help them directly find the home and live in it, and it's going to be a long-term solution. Food. There are some examples of getting, it's not just like Dr. Marubi had mentioned, not just having a McDonald's around the corner, but are they eating healthy food? So some of the programs we can do is with school districts for healthy food policies, some of the food service departments in your local administration, you can talk about it in health fair, supporting healthy food habits and information and education about it. You can actually work with food banks. There have been studies showing the role of food banks also in care for patients and mitigating some of the health insecurities and risks with that. The problem with that is the number of food banks to client that they needed is not actually good. There are more clients than there are food banks. The donations are not increasing, and they're usually not also adequate. And the staff is not always available, not also qualified staff who can educate. So sometimes partnering with some of the food banks around, maybe finding some creative ways of you partnering with them, helping them, guiding them. That's another option where your patients can actually be directed to those kind of interventions. Transportation and access had been mentioned here. Some locations can actually arrange for transportation. You might also, there are nonprofit organizations and nonprofit companies that are actually willing to take patients. Sometimes what is problematic is the patients being able to use or communicate themselves or arrange for their transportation. So sometimes you might want to do that. Outreach clinics inside those communities or mobile clinics in those communities will be a solution. I will end by giving an actual example. I think today, this has been mentioned, and I'm sorry that Dr. Lisa Ochoa had to leave, but she's having her private practice, Save Clinic, that she created in San Antonio. She based her work based on identifying in San Antonio the zones work as far as higher amputation rates, low socioeconomic status, higher COVID mortality. All of those zones actually were correlated together in San Antonio, so she could identify the high-risk population. That's where she also had basically based her clinics, outreach clinics. The outreach clinic is a mobile clinic where it goes with ultrasound ability, wound care team, herself as a physician, her nurses, and they basically go to the community instead of bringing the community to them. But also, if they needed to bring the community, then basically they help and assist with some of the transportation options because insurance can help with that. It's just that they absorb the admin burden of arranging these for a patient. They collaborated with community health workers. Those are people who are members of the community, share the ethnicity, language, socioeconomic status, and basically can help in interpretation, provide culturally appropriate health education, help the people with the care that they need, and they can help you with everything that you can also improve the screening and help us with everything that we want to do with outreach and build the trust with some of those communities. She's definitely had utilized that as well, including working with some people who could help the patients get insurance. And based on her experience, the majority of patients, the problem with not getting insurance is that sometimes they're not even knowing how to start the process. How do they even fill that? A lot of them are qualifying for some kind of insurance. They just need help with someone helping them and guiding them doing it. And sometimes it's worth having someone in your office or partnering with someone who can help you with that. So again, there are different names for employment, for community health workers that they can assist at. We're underutilizing it, but they definitely have been proven to improve access to health care, increase the screening, and enhance the relationship between us and the community, and reduce the need for emergency services. So all of those things are things that are available currently to think about as options. But what do we need to do for the future? I think understanding more and more that this is a change of culture. This is something that needs to be addressed at multiple levels. And the way to address it is from top down and bottom up at the same time. We can't just wait for policy to change. We can't just want the leadership buy-in, but we can start from down as well as we're working on getting leadership on board. So it's multi-level, multi-layered work. It needs to be something that ingrained in the culture. And we can't do it alone. It's not just about us in the hospitals or in the clinic. We really need to align with other resources and partner with a lot of the existing resources in the community that are there and work together to improve these these opportunities for our patients. Looking at the literature, there's, as I said, a lot of data about the correlation, not much about the interventions. One of my talks today with Dr. Ochoa is I would love to see her write about her experience, about what she's doing, because we can learn a lot from her. That's what I ask from anyone who's doing something like that, anyone who has a system in the hospital about helping social work with the patients. I think the more we see it, the more we see the correlation with outcomes, the more we have standardized care, evidence-based care that can help us actually mitigate some of those insecurities and help us design and develop actual tools that have been validated that are related to vascular surgery and to our patient population. So I would like to thank everyone. Sorry for the little bit longer time, and happy to have a discussion and questions on the topic.
Thank you so much. I think in the interest of time, we're just going to keep, oh, sorry, yeah.
Are there any places where we can like easily figure out what resources are available to us in our community?
So every state and every city has different, because that was one of my first questions to Dr. Ochoa, right? Like, how do you do that? How do you know that? And so she had collaborated with her council members. She went to see what her community actually has. So I think it's different. The problematic part in the U.S. is that every state is different, every city is different, right? But knowing that these things exist, meaning that when you're going to do it in your own place, you're going to have to do your own homework. You're going to look to what your community offers. You want to talk to your council members. There are apparently funds that are allocated in certain cities and states just for the patients that are uninsured, that sometimes they are willing to give you as a clinic to build up some of those programs. We just didn't even know those things existed. And so I do think that, unfortunately, there isn't a formula that's written. And I think the important part of writing some of the success stories is actually knowing the ideas of where it comes, who do we contact, who do we ask. But one of the things that I would ask her, but she's like, I had to become friends with council members and start talking to people. I've never talked politics. So it's not about you're with this or with that, but you're going to advocate for your patients. So you have to get out of your comfort zone and ask questions that we thought is not part of our role, right? And just to kind of find out what happens. But most of the studies that you read, there are a lot of community-based opportunities that we're usually just not aware of.
Thank you very much.
Thank you.
Our next topic is a novel approach to AV fistula with irreparable outflow obstructions, technique and outcomes by Dr. Mize.
Thank you for the introduction. I'd like to thank the program committee for allowing us to present our work today. We have no disclosures. Fistulas with venous outflow obstruction pose a severe problem to all parties involved, but especially to the patient, as it causes poor clearance and severe pain and swelling of the extremity. It can occur in multiple locations, including peripheral stenosis, all the way to central vein stenosis and occlusion, which is extremely hard to treat. Some treatment options for central stenosis include first rib resection for TOS, SVC reconstruction, occasionally bypasses or hybrid options with recanalization and stenting of the occluded portions. But what if you can't reopen or keep open the outflow? I'm here to discuss a novel approach to fistula dysfunction in the case of irreparable central stenosis or occlusion. The general dogma for untreatable outflow stenosis in a patent yet dysfunctional fistula is that you can ligate it and start over. You can place a graft, but we know this has shorter longevity and higher revision rates. Or you can move to the leg or place a catheter. I'm here to ask you to stop thinking of this dogma and to ask yourself, why sacrifice a mature autologous conduit and start from scratch, or place a catheter that likely caused this in the first place? Instead, translocate the fistula, recycle the vein, and make one arm's trash another arm's treasure. At our institution, we've successfully performed this technique in 4 patients, aged 43 to 80 years old, and all had patent fistulas with severe symptomatic, unreconstructible venous outflow obstruction. Prior to translocation, you want to do a contralateral upper extremity and central venogram for planning. You also want to do a surgeon-performed ultrasound to assess for optimal inflow and outflow on the receiving arm. In the OR, you'll expose the fistula and get length of the new autologous vein conduit. You'll then harvest the fistula and repair the vein and the artery on the donor arm, and then evert the fistula to remove any retained valves or intimal hyperplasia. Also taking care to repair any large pseudoaneurysms that are present, or you can move more proximally on the arm to find unused components of the fistula, as seen here. You'll then create a superficial tunnel between two incisions on your receiving arm, perform the arterial anastomosis using a parachute technique in our experience. The parachute technique allows to accommodate for the size discrepancy between the arteriotomy and the vein orifice. You'll travel less distance on the arteriotomy and further distances on the vein so that once you tie down the suture, it will cinch the two together and reduce the size discrepancy as seen here. You'll then pass the vein through the tunnel pressurized to reduce twist and kinking, and then perform your venous anastomosis. So while this is a complex procedure, it is a very doable operation. Our average OR time to date is 400 minutes. It's durable with a 100% primary assisted patency rate at 1 year. The average time from implant to clearance for use is about 44 days, with the earliest being 20 days. And we consider it a superior alternative to ligating an autologous mature conduit. And you can have an arm preoperatively that looks like this to looking like a normal arm with a functional autologous conduit on the other side. Thank you.
Sure, maybe I can ask the first question. There's certainly a cohort of patients who, even after ligation of the fistula, their arms remain very swollen. So I'm just wondering, what is the patient selection criteria for this procedure for you?
Generally, our patient selection criteria has been those that have tried multiple interventions previously to open up centrally, usually endovascular or doing a patch more proximally if there was more proximal stenosis. So usually it's patients that have undergone multiple procedures and are still having significant amount of swelling and pain and issues with dialysis.
Moslami, this is a nice idea. I'm just wondering, why do you have to wait 40 days or so to clear to use it? Because it's already been used in the other arm. Can you just like plug it in and use it?
So in general, we are able to use it. Like I said, one patient was as early as 20 days. We really just want to make sure that on the receiving arm, the incisions are healing. It's going to sort of scar in. But otherwise, you are able to use it much earlier than if you were to start over and have to wait for it to mature. The particular patient that had, it was a bit of an outlier which caused it to be about 44 days on average until use. He was hospitalized for other reasons and just had a prolonged hospitalization.
Yeah, I guess what I'm asking is that it's already matured in the other arm.
Correct.
Can you just plug it in and use it and skip those two incisions? Like, you know?
In our experience, we haven't tried that yet, but.
Thank you. It's a very neat idea.
Linda Harris from Buffalo. So my question is, where are you reimplanting these in terms of the venous end, and are you sacrificing outflow? If you're going in the upper arm and you had a vein that was suitable in your forearm, you may have just eliminated an option. So are you putting these forearm, upper arm? How do you decide?
Thank you for the question, Dr. Harris. So in general, our arterial anastomosis is generally forearm radial artery, and then we have been doing the venous anastomosis in the very distal upper arm, usually antecubital vein for one, brachial vein for another.
All right, thank you very much. All right, as we continue, the next topic is cost effectiveness of endovascular versus open arteriovenous fistula curation in the United States. Our discussant will be Bianca Mullaney.
Thank you for the opportunity to present this work. We have no disclosures. In the United States, $2.8 billion is spent on vascular access and its complications annually, which is significant cost burden and significant portion of the vascular surgeon's caseload, I assume, especially for people in this room. Endovascular arteriovenous fistula creation, of which you can see two examples, the ellipsis and the wavelength playing on the screen, is a relatively new, minimally invasive alternative to traditional surgical AV fistula creation in up to 60% of patients based on anatomic criteria. And yet the clinical and financial impact of endo-AVF in the US remains uncertain. But one way we can get at this question in the absence of concrete data from an RCT is a cost-effectiveness analysis where we create an economic model to forecast the outcomes of two different approaches. Just stepping through our model, it's a standard cost-effectiveness analysis model that consists of an initial decision tree in which our cohort is randomized to either undergo endovascular fistula creation or surgical fistula creation. It also incorporates technical success rates as well as maturation rates, which includes any procedures needed for maturation. And those that mature then transition to a long-term probabilistic cohort state transition model where everyone starts out as functional, but then you can transition into the non-functional state, in which case you would undergo one of the following open or endovascular rescue procedures. And then there are three possible ways of exiting the model. You either undergo renal transplant, you die, or your access is abandoned, aka loss of secondary patency. And this model runs for 5 years with standard economic discounting. In terms of the parameters that were used to generate this model, we conducted a systematic review of the literature. Our parameters are grouped into 3 buckets. One are inputs, which are weighted averages from all of the estimates in the literature of technical success rates, maturation rates, primary assisted, and secondary patency rates. The second bucket is utility values, which come from 3 studies. And then our last bucket is costs, which comes from the Medicare 2022 fee schedule. Looking at our results, the main result from our base case scenario is that endovascular AV fistula formation is not cost-effective relative to surgical. Just walking through this graph here, on the y-axis is costs, on the x-axis is quality of life years. And you can see that each point on the graph plots the average quality adjusted life years as well as costs that are accumulated over the 5-year period for one person. And although endo-AVF increases qualities by a little bit, about the equivalent of 1.5 additional months of life for a patient with ESRD, it's at significantly greater costs. And when you calculate the ICER, which is the incremental cost effectiveness ratio, taking the difference in the cost divided by the difference in qualities, that is $227,500, which is not cost effective when you consider a standard willingness to pay threshold of $50,000 per quality gained. One advantage of a cost-effectiveness model, though, is we can vary the parameters in our model to see how that changes the result. And in this series of one-way sensitivity analyses where we vary each parameter one by one, this tornado diagram is plotting the ICER for each variation. You can see that it really helps us understand which of these parameters in our model are driving the model output and the difference in cost-effectiveness. And zooming in on these first 7 variables, there are 5 in particular where once they are varied to a certain point, endovascular AV fistula creation actually does become cost-effective at the $50,000 threshold. So the first criteria is when the endovascular AV fistula maturation rate is greater than 90%. And for reference, in our base case scenario in the model, that is 78%, which is based on the weighted average from our estimates in the literature. When the additional quality adjusted life years gained from endo is greater than 0.12 qualities per year, which in our base case scenario was 0.03. When the surgical AV fistula maturation rate is low, less than 65%, for reference, the base case was 78%. And then when either the cost of of surgical fistula creation is high, or when the cost of the initial endo fistula creation is low. And I'm going to dig into that a little bit more on the next slide, because when we run a 2-way sensitivity analysis, varying both the cost of initial endo creation and the cost of surgical creation, there's a clear linear relationship that emerges where endovascular fistula creation becomes cost-effective whenever it is less than $600 compared to surgical AV fistula creation. And for reference, again, this is our base case scenario using the 2022 Medicare reimbursement rates. The cost of surgical creation is about $3,600, and the cost of endovascular fistula creation is about $16,000. So the red area of the graph is where surgical dominates. The blue area of the graph is where the ICER goes below the $50,000 threshold and endo dominates. Just to summarize our key findings, again, in our base case model, endo AVF is not cost effective compared to surgical. However, it does become cost effective when either the initial cost of surgical is $600 greater than endo, when the additional quality adjusted life years gained from endo is more than 0.12 per year, when the surgical maturation rate is assumed to be less than 65%, or when the endo AVF maturation rate is assumed to be greater than 90%. There are a number of future directions for this study. I think an RCT is definitely warranted, which Dr. Wu and colleagues at UCLA are already underway. We could also think about comparing different types of endovascular devices to better understand between device variability. We could also gain a better understanding of how the upfront learning curve to endovascular devices is contributing to the cost. We definitely need more studies to understand the quality of life differences, and also a study to understand what the potential equity impacts of this will be. Thank you so much to our team, in particular Dr. Elizabeth George, my PI, and my personal email is listed here as I'm currently in transition to residency. Thank you.
So it's a really interesting topic. Before we get to the question, I just want to, I'm wondering how many people are actually using endo AV fistulas in the room. I'm just curious. Can you raise your hand if you routinely use endo AV fistulas? It's a very small amount. Go ahead, please.
Well, thank you very much for this outstanding presentation and exploring a very important topic. One of the questions I have, one of the things I've kind of discovered as we do more of these, is the fact that there is a place of service difference, that it is possible, I haven't done it yet, but it is possible to do this in like an OBL setting. And certainly the costs associated with doing anything in an OBL setting can be, in fact, an order of magnitude less than it is in the operating room setting. There's no anesthesia, there's no OR time, it's not an OR. And so that can actually lead to significantly less cost, not just for the initial creation, and I think there's some new CPT codes for 2023 coming out, but also for the maturation procedures, which are inevitable. And I think it's very clear that the endo AVF does require more assistance to get going. Did that enter into your analysis?
Yeah, that's a great question. So the way it entered is through our sensitivity analyses, where we included the costs from Medicare that would be in an ambulatory surgery setting versus a hospital setting. The cost for endo, I believe, isn't quite different, and I think that has to do with the device costs actually being the main underlying driver of the increasing endo cost. When you account for the difference in the hospital fee versus the ASC fee, it's within this region here, and it's still not within the $600 to become cost effective.
What about an OBL setting, which could be a different set of economics as well?
I'm not sure about OBL settings, although the way you could take this analysis is if you assumed, basically this is looking at if you assume the cost of initial creation was anywhere between $2,000 and $20,000 and see where it lies.
Thanks.
I had a question also about your sort of conclusions, and to make endo AVF more cost effective, we either have to make it much cheaper, which I agree is probably device related costs, or it has to be a much better technique, because I don't think we're going to get worse, hopefully, at fistula creation. So how would you take that information and then hope to change practice or improve what we're doing?
Absolutely. I think one thing that came out from this study, just going back to the key findings, is that the maturation rates really impacted the cost effectiveness. And so I think this is an opportunity for vascular surgeons to partner with device companies to better understand how to improve the device capabilities such that further interventions, re-interventions for maturation are not needed.
Go. Will Jordan, Emory University, Atlanta. Thank you and congratulations on the presentation. More of a philosophical question. This technique is really innovative and looks cool. who should bear the cost of medical innovation and how we can introduce that into our entire vascular world? Thank you.
That's the ultimate question. It's a classic in all of medicine, really. How do we bear the upfront cost of innovation, and how does that factor into cost effectiveness? I think potentially taking a different approach to understand, maybe taking a more population health perspective rather than an individual patient perspective for a model like this could be a way to answer that question, to kind of think about overall social welfare rather than individual patient clinical outcomes, but definitely something to explore.
And as you embark on your vascular surgery training, and so perhaps you can answer this question before you get done, but also recognize that the U.S. Probably pays for the majority of medical innovation as it gets introduced throughout the world. But is it because of our health system? Is it because our capitalistic approach? I don't know, but I think this is wide open, and we have to figure out new techniques. So I want to figure out how to pay for it. Thank you again.
Yeah. And a testament to that is actually in the United States, we use higher willingness to pay thresholds in our cost effectiveness analysis compared to other countries.
London Guidry, LSU. I want to applaud you for being on the forefront. We're seeing our interventional nephrologists and interventional radiologists coming into this, and I think we need to be looking at it first. But my question is, did you separate out the different types of devices when you looked at cost?
We did not, and that is one of our future directions. There are now, I believe, if you go back to the literature review paper slide, there are about at least 5 studies that look at only the wavelength, 5 that look at only the ellipsis, and so potentially have an emerging opportunity to look at the variability between devices as well.
Yeah, and in regards to the OBL, the one device may seem less costly up front, but then the post-interventions are so high that that's added in, so you may be making money, and so it becomes a little bit maybe ethically challenging also.
True, although
the incentives versus disincentives.
True, although what we found in our model was, at least based on our current data, the overall patency rates at 5 years actually ended up being quite similar. It was really the upfront costs and the upfront maturation that was driving the difference.
Yeah, superb, thank you.
Thank you very much. This is exciting discussion, but we'll go ahead and move on to our last paper, Inpatient AV Fistula Creations Associated with Worse 30-Day Outcomes from the University of Pittsburgh.
Good afternoon. My name is Saad Hafiz, and I'm a research scholar with UPMC Vascular. We have no relevant disclosures. AVFs are considered the ideal vascular access for maintenance dialysis, but despite efforts to increase AVF for hemodialysis access, the majority of patients start with a tunnel dialysis catheter. Offering AVF creation to patients who are hospitalized for unrelated reasons may expedite TDC removal. We sought to assess differences in outcomes between patients undergoing outpatient versus inpatient AVF creation. We conducted a retrospective observational study of patients in the United States renal data system. We included all adults initiating dialysis with a tunnel dialysis catheter and later undergoing AVF creation identified by CPT codes. We created 2 groups, inpatient, which was defined as those admitted at least 1 day prior to date of AVF creation, and outpatient, those operated on at ambulatory surgical center or receiving same-day surgery. Our outcomes were 30-day mortality and major morbidity events, as well as 1-year AVF cannulation. We used multivariate logistic regression for our analyses. We identified nearly 69,000 patients meeting inclusion criteria, out of which 7.1%, or 5,000, were considered inpatient. These patients tended to be older, they were more likely to be of Black race, were more likely to have cardiovascular comorbid conditions such as hypertension, diabetes, and coronary artery disease, and were more likely to be non-ambulatory. On unadjusted analysis, we found that all rates of mortality, pneumonia, COPD exacerbation, MI, stroke, and pulmonary embolism were all higher in the inpatient group. These findings were robust even after adjusting for relevant confounding factors. We found that the overall adverse event rate was 7.0% in the outpatient group compared with 23% in the inpatient group. This is nearly 4 times higher adjusted risk. We found that access maturation was significantly less frequent in the inpatient group at 6 and 12 months. On adjusted competing risk regression analysis, an AVF treated as inpatient was 33% less likely to be cannulated. We assessed causes for admission and found that common reasons for admission in the cohort of inpatient group was congestive heart failure, pneumonia, sepsis, and an electrolyte imbalance. Complications were more frequent in patients admitted for CHF exacerbation, pneumonia, and sepsis, but not for those admitted for electrolyte imbalance and anemia. We conclude that AVF creation for inpatient individuals is generally associated with worse outcomes than outpatient ones. Our data suggests that for certain patients, a temporary delay for stabilization, medical optimization, and discharge with plan for expeditious outpatient OR scheduling may be associated with improved outcomes. Thank you.
Maybe just a really quick question. I'm not too familiar with your database. How can you tell that the events actually happened after the AVF duration?
So in the US RDS, it's generated from billing claims and and with the dates of the claims. So you can ascertain whether it was a preoperative or a postoperative event.
So we have maybe one last question from the audience.
Yes, sir.
Thank you. Michael Curie from Rutgers. That was a pretty interesting talk, and we just looked at a very similar analysis in our last 400 or so AV access cases and saw that the inpatients did a whole lot worse in every other way, just like you found there. But we saw that there are clearly very different patients, and there was a subset of patients that actually did as well. And I think that it's not them being an inpatient that's the problem, it's just the patients, who you're going to be operating on. And if you could still do it while they're an inpatient to help prevent that 3-week delay or month delay that you're going to get them into an operating room, that may be a lot better and less morbid than sending them out and trying to get them back.
So I understand that inpatient and outpatients, these might be 2 different patient populations. And from a statistical standpoint, we used propensity score matching to also see if we would find the same findings, and those were true. And to address your second question about is there a group that we can safely handle inpatient, that's one of the future directions, because we saw that patients who were coming in with electrolyte imbalances and anemia, we were safely able to create AV fistulas for them. And the one thing that we really want to see going forwards, and as a subset analysis, is to see in the inpatient group whether patients with complications or without complications had similar cannulation rates. So that is something which we hope to include in the paper.
Yeah, clearly there's a big difference between a patient who gets admitted for acute, onset of dialysis need versus being admitted for something else, and they're in the hospital for something else, and they're really a sicker patient. If it's just a straightforward dialysis access, it's a much clearer, picture.
Thank you very much. That concludes our session for today.